Go. Hi guys, welcome. We're going to go through tamponade and sort of pericardial physiology this week. Probably just going to do it without the whiteboard so much because I think probably everyone's going to know a lot of the echo stuff, and hopefully I can just go through with a few images from previous talks. So why don't we just have a bit of discussion about the questions that could potentially be asked, I guess, during the exam. I think the kind of exam question is always going to be along the lines of how do you recognize and diagnose someone with pericardial tamponade? How would you decide on whether you're going to drain someone with a pericardial tamponade, and how you're going to use echo to guide pericardiocentesis? I don't think there are going to be too many other ways that you can ask the question. So this is, if someone's asking a question on tamponade, it's a pretty easy one to be able to get lots of marks, I would have thought, because it's kind of, it's very well set out. So let's just go through each of those in turn, shall we? So Danielle, you're at the top of the screen. Let's just talk about, I guess, characterizations of pericardial tamponade. And why don't we do that to start off with obviously the 2D, and then we'll work down the list. Because if you're talking about how to diagnose tamponade, it's a pretty nice one that you can split up into 2D and Doppler analysis. So Danielle, go for it.
Okay, so on 2D imaging for tamponade, this is a pretty obvious statement, but you would expect to see a pericardial effusion.
Yeah.
And the effusion, the size of the effusion may not necessarily correlate with the likelihood of tamponade, because a slowly accumulating effusion can become quite large before causing tamponade.
Beautiful comment, yeah.
And the features of tamponade that you might expect to see on 2D imaging essentially is chamber collapse, so right atrial and right ventricular collapse.
And what phase of the cardiac cycle do those happen?
Specifically, and I don't have them in my head right now.
How about we go for the next one down the list? The team. It's absolutely right. So we've got right atrial and right ventricle collapse. We can also get left atrium or left ventricle collapse, but they're less common. Maybe start with me, a team. So let's talk about right atrial collapse in tamponade. When would that happen in the cardiac cycle? Oh, sorry, can you hear me, buddy? You got you on mute. The team, can you hear me? Oh, the old mute trick. Should we keep going down, or are you okay? So I still can't hear you, buddy. Yeah, try again. Sorry, man, can't hear you. Don't worry. We'll keep going down, and we'll see if we can do it. I'll take it off. We've got Ravi there. Ravi, can you hear me? You able to understand? Unmute audio. Ravi, you got me?
Yeah.
Great. Hi, guys. Can you hear me?
Yes, Sam. Can you please repeat the question?
Yeah, beautiful. So the question is that we've so Danielle was saying that we get right atrial and right ventricle collapse in tamponade. My question to you is, what stage of the cardiac cycle do they happen? Want a bit of reverb, guys? Is that no? Sorry, keep going.
Yeah. So, which stage of cardiac cycle? Sorry,
yeah,
Sam.
Which stage of the cardiac cycle does right atrial collapse happen in?
During systole.
Yeah, and particularly early or late?
Early.
Yeah, very nice. Yeah, exactly. And so the right ventricle?
Diastolic collapse.
Very nice. And early or late?
Early.
Yeah, so normally I have it as sort of late diastole collapse with the right ventricle and early systolic collapse with the right atrium. So again, it'll be a really common question they're going to ask, because it's obviously in the basic exam, saying the diastole or systole. I think they'd want for the advanced one, particularly saying early systole. And that's all based on, I'll just share my screen with you. Others will stop sharing it. Let's see if you've got my screen there. Can everyone see it?
Yeah.
What have we got here? Beautiful. Here you go. So here we've got the the stages of the cardiac cycle. I know it's left ventricle and left atria, but you get the kind of idea. And so during early systole is generally where we've got the lowest pressure in the left atrium, which is down there during early systole, and it's in late diastole with the ventricle. So early systole for right atrial collapse, and it's sometimes not perfect, but it's about then. And it's late diastole for the right ventricle in terms of the collapse. That's when they're at the lowest pressure. It's when they're at their lowest pressures they get squished. And let's go back to Danielle. So Danielle, you're absolutely right that we've got those in the collapse, the right atrium during early systole, the right ventricle during late diastole. Are there any confounders to that? Because we're using that to talking about characterizing and diagnosing tamponade. When might you not see that happening?
When the patient's not in sinus rhythm?
Yeah, good call. Okay, you're not in sinus rhythm.
Mechanical ventilation?
The wall? Yeah, nice. Mechanical ventilation, great call, and everything kind of gets messed up a little bit during mechanical ventilation. What about the thickness of the wall?
So if there's hypertrophy, I guess you might not see chamber collapse. I don't know, I'm guessing.
Yeah, fantastic. So if you've got hypertrophy, you can start to get a lot of these problems. In particular, I'm talking about chronic pulmonary hypertension, which can mess up some of this physiology where you might not get the right ventricle collapsing. It might be more like the left atrium and right atrium that are collapsing.
So if the right-sided chamber pressures are already very high because of hypertension, then they won't be overcome by the pericardial pressure so easily.
Very nice.
Okay.
The other thing you mentioned was you said that whether they've got tamponitis, whether they've got a space around the heart. Can you tell me more about that? How can you differentiate, first of all, a pericardial effusion from pleural effusion?
So on the parasternal long axis view, a pericardial effusion will appear anterior to the descending aorta, whereas the left pleural effusion appears posterior to the descending aorta.
Nice.
And you can also visualize the effusion in the apical windows and in the subcostal windows, where it may be more apparent that the effusion is encasing the heart rather than in the pleural space.
Is that always the case? Because you work at Codex and you work at Liverpool, right? You must see these where they're not that, but people are still in tamponade.
It's possible to have a localized pericardial effusion that can cause tamponade without being a circumferential effusion, and that would be very commonly seen in the post-surgical patient.
Beautiful. So I think if we characterize the tamponade on 2D, we say it's an echo-free space, and the size doesn't correlate to whether someone has tamponade or not. We can say it could be localized or circumferential, and you're going to get chamber collapse. And the chamber collapse will happen when the pressure in the pericardium's greater than the pressure inside the cardiac chamber. And so the most common ones to go would be the right atrium first, then the right ventricle, then the left atrium, maybe before, and then the left ventricle would obviously be pretty serious. I guess the sensitivity and specificity of those are far from 100%. Yeah. So where are we next to? Raymond. Keep going on some of these 2D features. So what else are we going to say? So we've talked about the echo-free space. How can you tell me what kind of, we've got blood, you've got exudate, you've got transudate that can cause pericardial effusion. How can you try and differentiate between the two?
Fluid will typically be very black, and anything that has tissue in it, anything that has tissue density will suggest that it has blood or organized blood. Transudates can also have some septations through it.
Yeah, nice.
Yeah, that's all I got.
Yeah, that's about right. Tell me more about the blood. You said the blood could be echo dense. A bit more about that.
So in organized blood, where the blood has clotted and has been there for a while, that it can look very much like tissue density, and so it can be very difficult to appreciate that there's a clot there. Fantastic.
And the last thing on 2D, so we talked about that space there. You can cheat a little bit and you can see it down here. I've written IVC dilation. Sorry, I've given you the answer there. What do I mean by the IVC dilation for the final characteristic of the 2D features of tamponade?
Well, it's fixed and it doesn't change with respiration.
Yeah, so we got something which we can call pseudo-tamponade. What's that?
There's I don't know, there's a hypovolemic state, I guess.
Yeah, perfect, exactly right. So you, if you've got pseudo-tamponade, you've got a collapsing IVC. You know, I think if you've got tamponade physiology, there's some pressure in the pericardium that squashes the filling of the heart. That's why it's a shock state, obviously. And for that to happen, it means blood can't get in. And so you should see a dilated IVC. So if you've got a collapsing IVC, that's known as a pseudo-tamponade. And the argument would be that you can give fluid to try and stop it being an obstructive state, because therefore you increase up the pressures inside the cardiac chambers. I think if you're answering a question on pseudo-tamponade, I think it'd be nice to put a little clinical caveat in there, which is my personal experience is I've never seen anyone with a pseudo-tamponade that I didn't have to go on and drain. You know, maybe it'll buy you a little bit of time, but you know, it's got tamponade in the title, and I've never seen a pseudo-tamponade not have to be drained at some stage.
Yeah.
Nice. So I mentioned again and again in these teaching the importance of your writing. If someone's asking a question on tamponade, you know, describe the, you know, how transthoracic echo could be used in helping a diagnosis of tamponade. I think the intro is really important to this as well. You know, the clinical side of things here, and you know, I'm sure I don't need to tell to you guys, but you know, this obviously is a clinical diagnosis first of all, helped by echo, and I guess that's where, you know, this MCQ comes from. You know, which of the following patients is in cardiac tamponade? Well, you've got both number 1 and number 2 are probably patients with severe tamponade or severe pericardial effusions. 3 is probably moderate, but you can see that right ventricle collapse happening there. And number 4 has got probably a small pericardial effusion. And obviously the answer to which one of these patients is in cardiac tamponade is the one who's in shock and breathless. You know, it's a clinical diagnosis. So maybe in the intro we should have said that, you know, the first thing, that clinical diagnosis backed up by echo. Hatim, how are you going with your audio? Are you going to, can you say anything yet? Are you able to talk? Yeah, we can definitely see you. Just as long as you can hear us, I think. We'll get at that. I'll hassle Carton. Carton, give me sizing. I just talked about these being mild, moderate, and severe pericardial effusions. Carton, how do you measure pericardial effusions so that you could put them into which category?
Well, we would categorize it as, I suppose, first of all, we would describe it as the presence of it, whether it's circumferential or whether it's localized, whether it is present throughout the cardiac cycle or just present in systole.
Yep.
And then we take a measurement of the maximum measurable distance, wherever that might be in diastole.
Very nice. And end diastole, yeah, very nice. And what are your cutoffs for mild, moderate, and severe?
I've got 1 and 2 centimeters in my mouth. The less than 1 is mild, 1 to 2 moderate, and greater than 2 is severe. And I think greater than 3 is very severe. I think there is, you know.
Yeah, I just had 1 and 2, just like you in there, and absolutely, if it's trying to get greater than 3, you know, like we can see in this case up here, number 2, that heart swinging around like a yo-yo is another sign of significant pericardial effusion. Beautiful. Right, I think that's probably about it on the 2D features. We've obviously mentioned the idea.
Can I just add? I would usually have a class of less than 0.5 centimeters as being trivial or physiological.
Oh, great comment. So my way of differentiating physiological from small is if you have an echo-free space throughout the cardiac cycle. I think that's the classic way it's described. So that if you've, so like this one down here in number 4. So I know it's been a bit tricky trying to see these So like this one here, we can see a pericardial space all the way through the cardiac cycle. So that would be small for me. If during the end diastole, you know, that you miss some of it, then that would be the physiological one for me.
Okay.
Right. Okay.
Sam, I have heard if the effusion is not present in diastole, and it's you can just see a little whiff in systole. That's
that's exactly what I mean. Yeah, absolutely. So if it disappears during part of the cardiac cycle, which obviously would be diastole, that's the way. Okay. Who's next?
Sorry, I had a question.
Yeah. Hi, Ravi.
You know, we mentioned the sequence of collapse from initially right atrium, then right ventricle, then left atrium. So does that mean left atrium is more stronger than the right ventricular chamber, or?
How about I'll show you this. This is what I have for that. So in terms of sensitivity and specificity, I think you get different sensitivity and specificity for each chamber being collapsed. It's obviously going to be the one that's got the lowest pressure that will get collapsed. And that's also dependent on that right ventricle ability to take that pressure, which means if there's a thicker wall, it's harder to collapse. So I think it's going to depend on the underlying myocardial state, so to speak. So I think generally, I think we see that it's normally the right atrium that goes first, then the right ventricle, then the left atrium. They've got different sensitivity and specificity. And I'm sorry I don't have it on here, but if the left atrium is collapsing, normally that's quite a specific sign, I think. So, yeah, I think it can vary, but I think normally it's the right atrium first, then the right ventricle. I don't know if anyone has any other comments about that. They've seen anything different.
I think the left atrium collapses quite early. It's just that we can't see it very easily. And so normally it's right atrium, then left atrium, then right ventricle. But as you're right, it'll depend. Remember, the right ventricle pressures go down to zero, while left pressures are often not. But no, I think the left atrium does collapse, but you just don't see it, so easily. We don't get a very good view of the free wall of the left atrium.
I guess that reminds me for another nice point to stick in there when talking about how to assess when you're trying to assess someone for tamponade, is the importance, first of all, I think it's the integration of clinical findings into the echo examination. Echo just backs up the diagnosis of tamponade. And the second thing is to use all available windows. We're not just looking this on one view alone. Okay. And guys, I'd just like to introduce the newest member. I think someone who hasn't never joined Fight Club before. We've got David Clancy, and I think we've got Lee Fitzpatrick, who've just joined us from Albury down in Victoria. So welcome, Lee. Welcome, David. Really nice to have you a part of here. And David's got his face as well as his DDU critical care, and he's one of our examiners. So, David, if you've got anything you want to add, just chime in at any time, okay?
That's okay.
Nice, fantastic. Okay, so Danielle, you told us the difference, how to talk about the pericardial versus a pleural effusion. Here we've got a little bit of both. You said it's the pericardials are obviously anterior to the descending aorta. I'm going to add in a few other things. It doesn't usually overlap the left atrium. What do you say? It can be associated with, rarely greater than 4 centimeters. I think that's probably a fair comment. And you might see the heart moving around. The the pleural effusion is posterior to the descending aorta. It may overlap the left atrium. It's never between the right ventricle and the diaphragm on subcostal, okay? And it can be greater than 4 centimeters. How about the pericardial effusion versus the fat pad? Who we got to go? I mean, Lee, do you want to go at this? I know you're just sort of kicking off your echo stuff, but Lee, do you want to take us? How would you differentiate a pericardial effusion from a fat pad?
So I think the fat pad should be snowier in appearance or less uniform.
Yep, nice.
And then I expect less variation in the thickness of it through the cardiac cycle. And I don't know that you get it posteriorly either.
No, it's normally just anterior, absolutely. So you normally, here's an example of the fat pad that's just sitting at the front of the heart, if you can see it. And it's this, yeah, so it's anteriorly placed. I often see it's got like some debris in it. It looks some some echolucent substances that are floating around in there. And the big one for me is that it moves in concert with the heart, as in it's stuck to the heart. You can see it flapping around and it moves with the heart. And as you say, it's got this kind of relatively sort of uniform appearance. There's always some kind of space there. That's good. All right. Right, who wants to take the tough bit then? Let's go on to, who's sitting there, DDU, next? I think we've got Danielle. You're sitting next here, aren't you? Yeah, right, Danielle, right. Let's bring you back down in. So help us out with the Doppler. And this is, again, an important part of it. How can Doppler help us with diagnosing a tamponade?
So you can use pulse wave Doppler to look at mitral and tricuspid inflow patterns, and looking for an increased amount of respiratory variation.
And do you have cutoffs for those?
So some sources just say 25% for mitral and for tricuspid.
Yeah.
Other sources I've read say, I think 25% for one and 30% for the other, and I can never remember which way around it goes.
Tricuspid's always worse. So remember that the right side of the heart's, I guess, a thinner structure, more dependent on the pulmonary vasculature. So you've always got more variation in your right-sided
than the left side. That's a good way to remember it.
Yeah.
And so you would be looking for an increase in the tricuspid inflow velocity of at least 30% after inspiration.
Increase of it, yes, very good. Yeah, so I had
a decrease in mitral of 25% with inspiration.
Very nice. And why is that? Really nicely done.
So it's an exaggeration of the normal physiological response. So it's called sort of paradoxus, but it's not paradoxical. It's just an exaggeration of the usual. And so the negative intrapleural pressure causes increase in RV inflow.
Yeah.
Whereas that results in decrease of LV inflow.
And what about during mechanical ventilation?
Yeah. It's different.
That's about as far as I go. I think they've actually asked this in the exam before, and I'm sort of with you, and I'm like, yeah, it's different. I think it's really hard. It's never been described very nicely. All I think you can say with a lot of confidence is that during spontaneous breathing, as you say, you're going to get a decrease in inflow during inspiration in the mitral valve and an increase in the right ventricle, which is why you get the interventricular septum gets pushed over. And during mechanical ventilation, a lot of those changes are not as obvious. So I think what a quite nice thing to describe if someone talks about how you use echo to manage your patients with tamponade, for diagnosis, saying that it can be a little hard in patients who are being mechanically ventilated. And I probably opt for draining these things more in patients who are mechanically ventilated, who are in a shock state, because I find it a little harder to diagnose, because in terms of the clinical diagnosis, I'm relying very much on shortness of breath, to be honest, shortness of breath and shock, and particularly shortness of breath lying down flat. And when someone's stuck on a ventilator, most of the time, they're in a shock state anyway, and you can't really ask them about shortness of breath.
Yeah, I think you would have to acknowledge that category is a limitation of what you can achieve with imaging, and the clinical judgment has to play a large part in decision making at that point in time.
Yeah, good call.
Can I ask, loculated, I assume we'd rely on a surgeon to drain that, or to...
Yeah, great call. Yeah, absolutely. So here, this is an example of a loculated pericardial effusion that you can see, particularly post-operative. So cardiac surgery is probably the one where you'd see this. And I know, obviously, a lot of you guys work in these centres, so please speak up if anyone sort of has anything to say about these. But absolutely, I normally don't try and go in and get these. This is where you'd be talking to a cardiac surgeon. Ray, you do a lot of cardiac surgery, don't you? You're a cardiac anaesthetist. You would you ever have a go at a localised pericardial effusion?
Never. I've got surgeons at my beckoning.
Yeah, perfect. There are a couple of other ones in there which you can talk about, right? So let me just... So there are a couple of other ones that if you want to go for the prize, you talk about echo picking up pericardial effusions. You can talk about variations in the pulmonary venous flow with inspiration greater than 25%, hepatic diastolic flow with expiration and increased AR velocity with expiration, lengthening of the interventricular relaxation time with inspiration. I have to read these off to try and remember them because it's not something that obviously I use clinically. I think if you can remember these, that's great. If you mention these before you talk about right atrial collapse and right ventricle collapse, you're going to get the examiner offside super fast, I would have thought. So I don't, these wouldn't get a major mark for me in the exam unless someone's got all the other ones done and they've answered them well and then they put these in. Then you can say, yeah, then they've got 15 out of 15 and they should get the prize. But just be careful about writing them down first. Oh, sorry, and more. And the SVC flows, decreased diastolic flow with expiration, increased air velocity with expiration, and lack of inspiratory increase in forward flow. Yeah, I think mainly clinical correlation. If they've got a massive great effusion with chamber collapse and big respiratory flow variation, that's the big one for me. Okay. This is a bit of an... Okay, I'm going to talk through this one real quickly. And then we're going to go on to some other cases which I think are a little harder. So we've got a 79-year-old female, met call for hypotension and shortness of breath pretty soon after someone's tried to put in a pacemaker and the procedure was abandoned. And this patient's hypotensive and short of breath, so they're mixing the clinical criteria, so that's the first tick. And then the next thing we'd be seeing would be a big echo-free space. We're going to measure it at end diastole, and we can see here that it's at least 2, if not 3 centimeters. Circumferential, heart swinging around, right ventricle free wall collapse during systole. And here you can see it's not exactly in early, it's not exactly the right ventricle free wall collapse in late diastole, you see here. And again, it's pointing towards a large pericardial effusion. We need other views to go and back it up. And we're looking for right ventricle free wall collapse and right atrial collapse. Use all available windows to diagnose it. We can see our right atrial free wall collapse during early diastole, right ventricle free wall collapse, which should be during late systole. Sorry, other way around, sorry. Right atrial collapse during early systole and right ventricle collapse during late diastole. And using all available windows, don't forget to look at the IVC for collapse to try and make sure that you can diagnose pseudo-tamponade from true tamponade. So if you've, going through those, if you're seeing a tamponade, if they bring it up in the vivas, getting that kind of banter to try and get through the case as fast as you can. So how do you use echo to help guide drainage? Ray, take us through this one. So drainage, using echo to guide drainage. Do you use echo to guide your drainage of these things?
No, I don't. But I would use subcostal view, and my approach would be a subxiphoid approach.
Yep.
And I obviously do it in plane with a needle. Do
you know how to use echo to do it, though? Are you aware of the technique? Because it has come up in the exam, and they'd be expecting you to know how to do it with echo if you did want to do it with echo.
Look, I mean, I've been using principles that I use for regional anesthesia and using ultrasound there, of keeping the image, the needle in plane, and visualizing the length of the tip.
Do you always go subcostally even if you're using the echo?
Well, I don't know.
Because maybe ask anyone else. Danielle, does anyone use echo a lot to drain these things?
So the alternative, I guess, would be to use an apical approach.
Yeah.
But I'll admit I have no experience in doing that. And so my approach would also be subxiphoid, using the subcostal.
Okay, well, maybe if people aren't doing this a lot, maybe I'll take you through, I guess, how they'd expect you to answer it in the exam. to talk about the potential. And if you do see a tamponade using it, maybe think about trying to do some of this. So I think I've got any good pictures here. Yeah. Okay, so the use of echo is useful because if you've got a nice echo picture, there's no lung in the way, obviously. So one of the first things to say is using echo to guide drainage of the tamponade is that you can find the biggest space and you can choose then the echo with off-axis imaging to try and find the direction where you're going to cause least damage. So the big danger areas that you're going to get into when you're draining a pericardial effusion is sticking the needle into the left ventricle or pranging particularly a coronary artery like the LAD. So those things are the way you can kill someone. Of course, you can also put the put your needle into your right ventricle if you're not careful, and that's pretty scary. But it's not actually going to cause a lot of damage, amazingly enough, according to cardiothoracic surgeons I've spoken to. I'm trying to avoid it, obviously. So, I guess trying to have a look at these pictures that we've got here. You can particularly have a look at this number B. So you can use your echo to guide you subcostally. The benefit of that is, so each section's got benefits and positives. So if you go subcostally, you're always going to have about 5 centimeters to go through. You're also going to have to go through the diaphragm, which particularly in young patients can be really tricky to try and dilate. I don't know if you guys have found this from doing subcostal approaches all the time, but I can sometimes in a difficult way, you've got the dilator all the way in, you take out the dilator and you still can't feed over the pericardial drain because the crura of the diaphragm is so strong, you open them up and then because it's such a thick sort of fibrous structure, it then closes straight off again. And so often, even with all the dilation in the world, you still can't put your pericardial drain through. The good thing about it, though, is, if you go too far, you're just going to stick it into the right ventricle, which is, if you're going to stick it anywhere in the heart, it's probably the best place to stick it. Obviously, try and avoid it. And the last thing I'd say about the subcostal approach is I have drained a pleural effusion, not a pericardial effusion, when I've gone from the subcostal approach. So if you do have someone who's got a pericardial effusion and a pleural effusion, I always drain the pleural effusion first to try and make sure if I'm going subcostally, I don't drain that. So that's the advantages and disadvantages about the subcostal. The parasternal approach you can also go for. And as you can see, the reason why I'm showing you this one here is this approach is that you can then go off axis to make sure you're heading away from the heart. So you can, instead of just having, like if you're going subcostal here, you've only got maybe a 3 centimeter landing zone. If you go off axis and aim away from the heart, you can have a 10 centimeter landing zone. And that's just using your echo probe. As long as you've got to be good with the echo. And as long as you're using it to line yourself up absolutely perfectly, you can, I use a sort of a mark and then stick the needle in approach rather than going real time, but you can do both. But you can give yourself a bigger landing zone by going off axis. And the same principle applies if you're going apically. That area that the echo probe is on at the moment might be great for getting a forward chamber view, but I'm actually doing it when you're trying to drain the effusion, trying to figure out the least amount of stuff that you have to go through to get to your effusion. And once I figured that out, I then go off axis, and generally I point it so that I'm pointing the needle at the right ventricle, not at the left ventricle, and giving myself, the biggest landing zone. And that's where you can see that I've drained in this guy, which I actually think I drained with David, didn't I? Dave, I think this was the guy that you and I did a few years ago. But you can see the direction of that needle. That is not the direction that you'd be getting an apical 4-chamber view from. I've swung it round and aiming up so that you've got the biggest landing zone and you're going away from the right ventricle. And it looks bloody awful. I love this picture, just seeing it bobbing around. It's a little disconcerting, I'll be honest, but I promise that was in the right spot. Oh, and I can prove that to you. There we go. So here you can see that I'm going away from the heart. I'm aiming more towards the right ventricle than the left. So always think, what do you do if you advance too far? And the apical approach is probably the most dangerous. And there's an example of a parasternal approach, again using echo. And again, try and pointing it away from the, pointing in, if there's an echo-free space, you want to go parallel with that echo-free space if you can.
So Sam, are you saying that while you're inserting your needle in these cases, you have the probe on at the spot where you're inserting the needle, or at a different spot, or?
The way, I think in the exam you say that you could use echo to find the place with the shortest distance you've got to get to your pericardial effusion. You can use it to help guide your placement. Mm-hmm. In a practical approach, what I do is if I've got the echo probe on their chest like this, mm-hmm. I imagine it's a lightsaber, or it's just an infinitely fine line, and I'll go off axis trying to find that greatest landing zone area. And what I do is I then pick a spot somewhere on the other side of the patient. So once I've got my echo probe in the right spot, I'll then imagine that line coming out of the end of it. I'll find a spot on the bed the other side, or somewhere that's not going to move. I'm all sterile at this stage. I'll then give the probe to someone else, generally to put subcostally or parasternally. Mm-hmm. And I'll have marked where that echo probe was with like the end of the needle cap. Mm-hmm. And then I take my needle, I go on that mark I've made on the skin. I know where I've got to aim it on the back, and you stick it in.
Mm-hmm. But with real-time imaging, but from a different window.
Well, I don't. So real time.
No real-time imaging.
So yeah, real time for me is actually watching where you're going with the needle. So I'm not using. I've got someone else putting the echo probe on to do this. So once I think that I'm in the space and I've got withdrawal of, fingers crossed, is pericardial fluid, I take out a few mils. I stick some on the bedspread to make sure it doesn't clot, because that's again another sign. But then after I put a couple of mils on the beds, on the what do you call it, the dressing gown, the drape, thanks. Then I'll put the needle back on put the syringe back on the needle, and I squirt in some bubbles. I squirt fluid back in. Mm-hmm. And what you'll see here is that you'll see the bubbles, hopefully in the pericardial space. You don't want to see the bubbles in the left ventricle or the right ventricle, especially not in the left ventricle. And you don't need to, I've tried this a few ways, and I hope David stays quiet for all of this, because I practice with him. Yeah. So one of the things that I used to do is I used to try and after you think you're in the right space, try and agitate some saline and use agitated saline to squirt it in. I've sprayed myself, the patient, other members of staff with water a good few times. I've tried to inject the agitated saline through a weird system that actually had a filter on, so the bubbles got destroyed, and I messed around a lot, and I did that with David. He's never let me forget it. I generally find the best thing to do is just literally take out a couple of mils of the pericardial effusion and squirt it straight back in. You don't have to mess around with any kind of agitated saline. Just the physical action of squirting pericardial effusion back into a space makes the bubbles look like this, and it lights up like a Christmas tree. And then I try and find the drain if I can. You can sort of see the drain sitting in there with the echo. It's a bit tricky. Okay? So they do expect you to know that technique. It doesn't matter if you don't use it, but they do expect you to know it for the exam, okay?
Sam, I had a question.
Yeah, go for it.
Would you use a contrast instead of other ways to contrast?
You do not need contrast. You don't need contrast for a couple of reasons. So first of all, the benefit of contrast is obviously that it can, small bubbles that can stay around for a little bit longer and can go through pulmonary capillaries to go into the systemic system. You don't need to light up the systemic system with this. You just need bubbles to let you know where you're staying. And as I say, in that regard, you can use agitated saline, but what I find easier is just sticking in the the pericardial effusion. So pericardial fluid. You don't need any specific content. Okay. Right. Let's do the next case. Are there any questions about that? So that's, I guess, from a tamponade point of view, that's all the questions that sort of they're going to ask in the exam. But they would definitely ask you, you know, you've got to know your 2D features, you've got to know your times of cardiac cycle, clinical correlation, looking at the IVC, and then variation of flow. Okay? Any questions about any of that before we move on? Okay. Right, let's do the next one. Let me see if I can make this work, because we haven't done this before. I'm just going to go to a machine over here, and we're going to go through the next case, all right? Can everyone hear me? Yeah?
Yes.
Yeah.
Beauty. Okay. Right, who's next? Yeah, can you hear me? Is that better? Yeah, beauty. Okay, who's... Oh. Is that better? No feedback now? Fantastic. Okay, so let's move on to other kinds of pericardial disease. Who wants to take this one? Because it's a little tricky. Who have we got? Raymond. Ray, do you want to take this one?
Sure.
Yeah, can you hear me?
Yep, I can.
Beautiful. Okay, so
we're not going to see patients' names, right?
you're not going to see patients' names.
Good.
No, I was double checking that, so hopefully...
Good.
Yeah, so hopefully it's just got, yeah, so you're not seeing patients' names. It should all be anonymized if I've done my job correctly.
Yeah, that's fine.
Cool. All right, let's go through this one nice and quickly. So this is...
Yep, so this is a personal long axis views that we're looking at, and I see a rim of pericardial fluid, echo-free space. I'm seeing RV diastolic collapse. I noticed that the left atrium does seem a little bit enlarged. What else can I see? There are some there's some trivial aortic regurgitation, maybe some mild mitral regurgitation. So just trying to time the diastolic collapse. I'd like to sort of slow it down and do it frame by frame to see when the
and what are you looking for?
Diastolic collapse. Yeah.
Yeah, so which ones are you looking for? Which chamber do you want to see?
The RV does look like it's collapsing.
Which would be your best views for that?
Well, I mean, you can use a peristernal long axis views to look at the top bit, but you can also look at apical four chambers as well.
I'll just slow it down for you. Does this come out okay?
Yep, it does.
Cool. So there we go. I think it's collapsed.
There is RV diastolic collapse there, yep. So you can also put MO in that.
Late diastole, we're seeing down here, we've got late diastolic collapse happening of the right ventricle. And then what's the rule if we're seeing it in one view?
I'm going to confirm it in another view.
Fantastic. Another one here for David Clancy, his love of M mode as well. Using M mode, I find it's a lot of people say that, M modes, shouldn't be used, it's got no place, but I still think it's great for things like TAPSE and timings and for testing people in exams. Because if you know about M mode, you know echo, in my opinion. So here we can see the right ventricle, this marker at the top, and you can see the collapse. You can mark it up during the timing of the cardiac cycle, and it fits very nicely here with end diastole. Beautiful. This is quite a nice one as well. So this one's a really nice view for picking up a couple of things. So as well as talking about the collapse of the right ventricle, which we can see up at the top here, we can also see that we've got some swing in the interventricular septum, right? So particularly during inspiration, we're going to see that as Danielle was saying, that during inspiration you get a decrease in mitral inflow and an increase in RV inflow, and hence the septum gets pushed over to the left during inspiration, right? And so that's what this image is telling you. So we can see, first of all, that we've got an echo-free space, and we can measure it up at end diastole and measure up the maximum area. So here it's about 1.5. So it's able to do something like that. 1.6, so we've got a moderate pericardial effusion. We've got right ventricle free wall collapse during end diastole, which is as we'd expect. And then we're seeing during inspiration, we're seeing, so yeah, during inspiration, we're seeing the interventricular septum being pushed over to the left. So it's a really nice picture, right? Cool. And I've put this up here. We'll just skip through all the rest of it. So obviously you want to use lots of different chambers to have a look at it. Here's your subcostal. Here's your short axis view, and you can see the right ventricle free wall collapse, and you can't really see the interventricular movement. And I wanted to show you this case for this reason. So what I didn't tell you was that the clinical presentation for this patient, who was someone with ongoing dyspnea, particularly on lying down flat, who's got a history of previous pericardial effusions and cancer, I think it was, who was in shock. So this patient was meeting the criteria for, it wasn't cancer, someone who had a kidney transplant, end-stage kidney disease, previous effusions, and this felt very much like that to her again. So clinically, she was in tamponade. But I use this as an example of sometimes I find it really difficult. You know, sometimes patients don't read the textbook. And here you can see that we're not seeing those huge variations in flow. You see the respiratory flow pattern at the bottom. Sometimes you don't see that. And I guess I'd use this as an example to say that sometimes it's not as easy as it is in the textbooks.
You can see that the patient's quite tachypneic, okay, because her heart rate's 90 and her rest rate is like every 3 cardiac cycles.
And I mean, I think in the exam, you know, what the examiners really like is, you know, this is an exam for clinicians, and talking about that, you know, if the question is how do you use echo to diagnose tamponade, I think it's not unreasonable to say, obviously it's a clinical diagnosis backed up by echo, but sometimes it's really hard because, you know, patients are really shortness of breath. They're short of breath. They've often maybe got different pathologies going on at the same time. And often you kind of got to drain the effusion and see how they go. I think in the meaning of time, I might just skip to the next case unless there are anything about that. That was what the main crux of that case was, just to show you that sometimes you can have features, but not all of them. And I still think that sometimes that necessitates draining effusions. All right, I'm just going to stop the share and I'll bring this back up in a sec. Just hang on a sec while I pull this up. Next patient. Okay, this is a good one. Can everyone see that okay?
Mm-hmm.
Just in the meaning of the word time, I'm going to skip to the money shot. So this is a 75-year-old guy who's just been admitted to the ICU with shortness of breath, needing increasing levels of oxygen, and he's got a borderline blood pressure. He has got a background history of hypertension, ischemic heart disease, and cabbages in the past. what do you think? Where's it gone? Yeah, here we go. Carton, do you want to take this, mate? So as I said, he's an elderly gentleman in his late 70s, early 80s. History of having ischemic heart disease and the cabbage, who is short of breath.
Well, you've got a apical four-chamber view of the right and left ventricle with the respiratory trace overlaid, and you're seeing deviation of the septum into the left. I'm seeing this at 4 frames a second.
Oh, sorry, man.
Probably with inspiration. So I think what you're trying to show me is increased interventricular interdependence.
Yeah, very nice. And it's during respiration. And
yeah.
I guess, like, what do you think the differentials for this might be?
Well,
I'll tell you what, let me give you a couple of other...
There's no pericardial effusion, which is...
yeah, there's no pericardial effusion, right?
Everyone else in the talk had one. And your label did say constrictive pericardial thing on the email. So I think that's what you're going to be getting at.
I am. So let me show you. So the big thing for me is if someone's got risk factors for having constrictive pericarditis, that would be someone if you've had previous infections in the pericardial space, if you've had previous cardiac surgery, if you've had radiation therapy. I think if you've had a recent, heart attack with pericardial effusion, a Dressler syndrome or something that's got better, you're at risk of having constrictive pericarditis. And the big symptom of that is shortness of breath.
Mm-hmm.
And the big feature that you're going to see that you've got to be able to pick up is that interventricular septal bounce, particularly during inspiration, where it gets pushed over. And that's exactly the same physiological principles that Danielle described with tamponade, where you've got that fixed pericardial space and exaggerated physiological response when you're breathing spontaneously.
Mm-hmm.
So what are we seeing? So what's the next thing you've got to do to diagnose constrictive pericarditis?
I suppose in an isolated, if that was the only pathology going on, we would reasonably expect to see things like the mitral inflow pattern would be restrictive pattern, but yet tissue Doppler would be preserved, would be the classic.
Yeah, it's not preserved. It's not preserved.
Well, it's often, let's say, more normal, and there's then this discrepancy between the medial and the lateral.
Yeah, why am I showing you this? What am I showing you an example of here? I've got Louise here who's going to talk as well. Louise was just saying it.
So it's low. Sorry, go ahead, yeah.
No, yeah, hang on a second. Let Louise have a word.
So if it was constrictive pericarditis, you would expect the lateral and the inferior walls to be tethered by the pericardium.
Excellent.
Therefore, the septal E prime is preserved, and the lateral E prime is less than the septal E prime and not preserved.
And what's that called? What am I showing?
Reversus.
Annulus reversus. Beautiful. So this is absolutely pathognomonic for constrictive pericarditis. So the big features that you're looking for constrictive pericarditis is, first of all, some risk factors. Second of all, some shortness of breath. Third of all, on echo, you're going to see that ventricular interdependence with respiration. It's very important with respiration. And then the last thing you're going to use is the big pathognomonic one here, which is annulus reversus, where the medial is higher than the lateral, and I'm talking about the E prime. So, and that's because, as Louise was saying, the lateral area of that heart is tethered. So annulus reversus equals constrictive pericarditis. The one last thing that you can look at, which is great for the exams as well.
Hepatic vein diastolic reversal is greater than expected.
During what phase of the cardiac? So during expiration phase. Great work. So here you can look at the flow in the hepatic veins during, ideally we should have here with the respiratory cycle, but you're looking at diastolic flow reversal that is worse during expiration. And that's the way that the classic, why I'm showing you that is they love asking, if anyone's doing the American Echo Board exams, they love asking about how you differentiate between constrictive and restrictive disease, and often you can do that. Restrictive has diastolic flow reversal that's worse during inspiration. This is worse during expiration. And so I think we'll be seeing this last cardiac cycle you're seeing here with a diastolic flow reversal that's worse during expiration for constrictive pericarditis. All right.
Sorry, can you just clarify that? So that's are we looking at it's a more negative velocity for the diastolic?
Exactly. So diastolic flow reversal. So again, I think it's basically difficulty in filling the heart because you've got the heart squished by the thick, horrible constrictive pericardium. So you can't fill the heart well. So during systole, it has a bit more of a chance, but during diastole, it finds it tricky and you're getting flow reversal then. And it's worse during expiration. It's worse during expiration with constrictive pericarditis.
I think, can you just point out to me the S, D, and A waves on this?
Yeah, it's not perfect, is it? I think this is the D wave that we're looking at here in diastole, and I think the A wave is in there. Your
cursor isn't coming up.
Oh, sorry. Okay, so I think the ECG is a little out from the flows. So I think the one that's pointing down is systole. Okay. And then I think the one that's right after the one pointing down is diastole. And I think the third cardiac cycle is the worst. I don't think this is a great example of it, but I think the third cardiac cycle is the worst. And I think that's during expiration. So you're looking for that diastolic flow reversal that's worse during expiration. This is not great for I don't think this is massively important for the DDU, but it's more for the American Echo Board exams if anyone's doing those. And I'd always encourage you to because it's a pretty full-on exam. But they love asking it in the American Echo Board exams. Just one of those, I don't know, one of those things. Okay. Okay, guys, let me just go. Let's just finish it up from here, okay? So that's it. Are there any questions about any of that? Everyone happy?
Yeah, I gotta go. Thanks so much.
Very much, guys. Take it easy. I'll talk to you soon. Bye.
Bye.